Over to Maj Shabir, who's going to do us an excellent talk. Maj is a consultant at Guy's and St Thomas', previous fellowship at the Institute, and he's going to give us a talk on rehabilitation. I should say also that you can submit questions via the iPad, via your app, and they'll come up on our screen.
Thank you, Richard. So I'm going to be covering what to do after the surgery. So we've already heard about the surgery can create some of the carnage. This is about trying to minimize the effect of that carnage on that patient's life in the long term, because when they do come to see you beforehand, it is all about the cancer. Am I going to make it through? Is everything going to be okay? And once they come through, it's about, well, how can I live like this? And it's all about quality of life. And when you look at the things which are going to impact the most on quality of life, it's going to be the sexual function aspects and, as we've heard, urinary incontinence. And of the two, thankfully, the urinary incontinence is the smaller group, but by far and away the most devastating. But what I'm going to focus on today more, being an andrologist, is going to be about the sexual function, because this is by far and away the most prevalent thing and something we can have more of a role in trying to improve in the post-operative period. Now, we call it sexual dysfunction as opposed to erectile dysfunction, and Declan's already kind of covered this to an extent as well. When you look at the papers, everyone talks about erectile dysfunction as if this is the only kind of be-all and end-all, and this is the only change that people get after they've had a radical prostatectomy. It is only one of the many things that happen, and there are many things that do happen. And if you were to look at the rates of different papers, they'll quote different rates of erectile dysfunction, but if you were to quote the rate of sexual dysfunction, it is 100%. Every patient will get some change in one of these different parameters given the surgery that they're going to have. And when you look at things like aspermia or loss of natural fertility, that may seem like a minor thing when you're looking at men who are generally in their 60s or 70s having surgery. But for some subgroups of patients, and from a cultural point of view, that could be their moment of regret. And we have had patients, for example, in our area coming through and refusing to have radical prostatectomy unless they sperm bank beforehand, which seems strange to you and I, but for some cultures that is the most important thing, and they'd rather die with cancer than have no chance of having a child later in life. So it's important, as you've heard, counselling before the operation has got to be the most paramount thing. A better prepared patient is a better outcome afterwards. They're more forgiving for what happens to them later on, and you don't want to have that regret situation later. So what is the true rate of erectile dysfunction if we're going to focus on that as our kind of primary measure? And that's certainly what all the papers talk about. Well, biggest problem is that there is no universal definition of what true erectile dysfunction is after you've had a radical prostatectomy. In fact, there was a nice study by Tal where they looked at all the different papers available at the time, 22 different definitions used in the different studies in that meta-analysis as to define what was erectile dysfunction. And if you have such a dichotomous group, you'll never get any true understanding of what you're dealing with. If you look at what people talk about, some people will talk about having assisted erections as a satisfactory outcome. Other people say it has to be unassisted erections. Some people say it has to be returned to what you were like before, either with drugs or without drugs. But which one's the most important to patients? I think most patients, and certainly as an andrologist, the thing that would hold true to me would be getting a patient back to where they were before. So if they had erections before which were unassisted, well then that's really where you want to get them back to if you're trying to do the best thing and the minimal impact from your surgery. And there is some data that shows that if you use those stricter definitions, then actually the rate of erectile dysfunction is much higher than expected. And again, age, as you've heard already, is one of the most important factors, and it does make a big difference. You know, if you look at patients over the age of 60, this is a study from Memorial Sloan Kettering, this is from John Mulhall's group, the return to baseline unassisted erections was only 4% in those over the age of 60. Under the age of 60, it was about 23%. That's unassisted without PD5 inhibitors. So we've already heard there are different things that you can do. There are things in the preoperative, different things you can look at. There are things in the preoperative phase, there are things in the operative phase, and things in the postoperative phase. Well, preoperative we can't change. The patient is the patient. Their age is their age. Their comorbidity is what they have. Assessing their erectile function is important, and I think most importantly, if we can do it at the stage of first presentation, before they've had a TP biopsy, which may interfere with some of their erectile function, or before they've had that diagnosis, when them filling out a questionnaire about their erectile function is now slightly skewed by what's just happened to them in their life. We've heard about surgical techniques and things which may or may not make a difference. As you've heard, robotic-assisted radical prostatectomy hasn't really delivered the big change that we thought. And there was an interesting paper from the States where they looked at regret, and they actually found that patients' regret was actually higher in those who had had a radical prostatectomy with a robot, because their assumption was that having a robotic operation ameliorated all of these side effects. And so actually counseling becomes even more important when you're using some of the newer technologies. Some mention about accessory pudendal arteries. not much about it in a lot of the literature, but some people have said that if you see it and you can preserve it, it may make a difference. But really, the nerve spur is what it's mostly about, and we've heard about that already from Declan. And why is it so important? Well, it's all involved in the pathophysiology of what happens in that post-operative period. Cavernosal nerve injury, and that can be even when nerves are preserved. The neuropraxia that occurs as a consequence of the mechanical stretching during the operation, the thermal injury, the ischemic injury that inevitably happens as well, can end up leading to changes in that neuronal function in the initial period, and that initial period may last many months. That will end up leading to cavernosal hypoxia because they lose their nocturnal erections, those unassisted erections. Losing that regular oxygenation of the penile tissues that happens at nighttime, which is part of your penile health, can lead to corporal smooth muscle apoptosis, and that can then lead to subsequent fibrosis. Change in the distensibility and compressibility of those nerves from fibrosis can end up resulting in veno-occlusive disorder, such that when your nerves do recover, you've already got established erectile dysfunction of a different mechanism. So is there something we can do to try to prevent that from occurring while the nerves are recovering at their own rate? And that's really where this post-operative element of rehabilitation comes into its play. So what should we do? What's the goal of penile rehabilitation? It's all about ameliorating those things we've spoken about, restoring both assisted and, most importantly, non-assisted erections, preventing those structural changes, which includes changes to the length and the shape of the penis, improving the blood flow to the penis, and trying to maximize that nerve kind of regeneration or ameliorating the level of damage. Now, people have been doing some form of rehabilitation in some shape or form for over 20 years now. And it's amazing that in that period of time, the data hasn't got a lot better, or our knowledge hasn't got a lot better. This was the first, the one that changed everything to start off with. Francesco Montorsi, 1997, took Cavaject and gave it 3 times a week to patients within their first kind of 3 months of having a radical prostatectomy. And he looked at the patients who had Cavaject versus those who didn't have Cavaject, and then looked at the outcome with regards to unassisted erections further down the line at 6 months. And if you had regular Cavaject from an early period, you had better unassisted erections at 6 months, 67% versus 20%. Now, people often think giving intracavernosal injections 3 times a week isn't going to be very acceptable to patients. And yes, there is going to be a natural attrition and drop-off rate. And in this study, about 20% of people didn't make it through that program. And from I think most people's practice, you'll find that about 30% aren't going to stick to a regime when you give it. But it was certainly interesting data because it was unassisted erections that got better in that time period. It's not the only study. There have been another couple of studies. This was a nice one that was done on patients who had had non-nerve sparing surgery. So they were given the same regime of intracavernosal injections 3 times a week from an early phase. In fact, they randomized those patients to giving them in the first 3 months of treatment or from 4 to 12 months afterwards to see if the timing made a difference. And if you gave it in the first 3 months and then looked at the number of patients who were achieving erections good enough for penetration later, they were better and more commonly occurring in those who started the injections earlier versus those who started it from 4 months onwards. And it wasn't just that subjective measurement. They also did Doppler scans and found that the peak systolic velocities in those patients was better if you started the Cavaject earlier. And that's in non-nerve spare patients. Other studies, this is again from John Mulhall's group, and these names come up time and time again in rehab studies, John Mulhall and Francesco Montorsi. Here they took patients who weren't responding to PD-5 inhibitors within their first 6 months, and they gave a cohort of them intracavernosal injections 3 times a week, 58 patients, and they left another group of patients without having any further additional treatment, just on the PD-5 inhibitors. And they looked at them at 18 months and saw the difference. Now, this was not a randomized controlled trial. It was looking at 2 different cohorts over a period of time. They found that at 18 months, those who had had the regular Cavaject from the earlier period had, again, a better rate of unassisted erections, statistically significantly. Not only that, but if you were to give them sildenafil again at 18 months, you had more patients in the group who had Cavaject earlier responding better. Again, ties in with some of the other studies. So again, it makes you think that intracavernosal injections may be something to use, and maybe the hang-up is more about how we approach it with the patients rather than what they may consider if they knew the data was fairly reasonable. What about vacuum devices? We all talk about them. It's very hard to get hold of them. In fact, most patients will tell them to get hold of it. They'll go to their GP and get left on this merry-go-round of trying to get hold of the device. The evidence shows that there is some benefit to using vacuum devices. The studies are not fantastic. They are not large. But they do seem to show that if you use them earlier, then you can ameliorate some of the structural changes to the penis in the sense of preserving your length and your girth by using it from an early period of time, and best within the first 4 weeks onwards. And Again, it's all about regularity. There's been some recent studies in the in vivo models that have shown that this is logical, because people used to think before that you're only getting non-oxygenated or venous blood that's coming into the penis with the vacuum devices, but they have actually shown in animal models you are getting some oxygenated blood coming in, and actually some of those smooth muscle apoptosis and fibrosis that we know about can occur doesn't seem to occur if you use the pump regularly. Biggest problem is that patients, again, don't like it. It's all about how you counsel them about its use. And if you counsel them well, actually the drop-off isn't as bad as you think. But if you give them a pump and tell them to do it of their own accord sometimes, you may get drop-offs of up to 40% of patients not seeing it through to the end. But what about PDE5 inhibitors? Well, this really changed the whole landscape of treating erectile dysfunction in all different other forms. And likewise, when it came to radical prostatectomy patients, this became the most prescribed thing and the most utilized rehab program. Well, in vivo, there's been very good studies which have shown that you can ameliorate all those changes that we spoke about before. All the things that we want to achieve can be achieved in vivo. But what happens in actual patients? And here's where the data kind of falls down a little bit. Now, over the last 10 or not more than 10 years, there have been a number of large studies which have been produced, and they can get a little bit confusing to look at. So what I've chosen is just probably 3 of the most key papers, looking at 3 of the most commonly used drugs: sildenafil, vardenafil, and tadalafil, and just to have a look at what they showed. So what does the data tell us? Sticking with the most key paper originally using sildenafil, here they ended up giving sildenafil every night, either 50 milligrams or 100 milligrams compared to a placebo. They gave it for 9 months in total, 36 weeks, and then they gave them a washout period for 8 weeks, and then saw what their response, or what their natural erection rate was like. Now here, they actually found that that unassisted erection, the thing that we kind of speak about as the holy grail of successful rehabilitation, was better in the guys who had had some form of treatment versus the placebo group. But overall, the percentage return was very poor. So the placebo group had a 4% rate of natural erections. Those who'd had sildenafil, either the 50 or 100, had about 25%. And that was much lower than they had expected overall, so they had to terminate the trial early. As a consequence, they were planning to get 125 patients. They had to terminate after 76. And it's difficult to know because it wasn't really powered at that level to give us the right answer, so we don't really know if it is the right answer. There have been subsequent studies which looked, Pavlovich did a study where they looked at using sildenafil nightly versus on-demand versus placebo, and they found actually there wasn't much difference between using the on-demand or the daily regime. The same thing's been found on subsequent larger multi-center studies looking at vardenafil. Again, on-demand versus daily versus a placebo. Similar setup, 9 months of treatment, 2 months of washout, and then seeing what the response was like with unassisted erections. Didn't seem to make any difference at all. So there's no advantage. Well, there was a difference when you were taking the medication, but not with the unassisted erections after the washout period. And in that particular study, using vardenafil, the daily dosing was no better than using the on-demand medication. But then along came tadalafil, and here was the first of the PDE5 inhibitors that was actually designed to be given as a daily dose, as opposed to the other, which was given as a regime. This has got the longer half-life. It has an additive effect if you use it for a daily basis. Could this have been the one to change the landscape? And there was a very large REACT multi-center, double-blind, placebo, double-dummy trial, which was prospectively randomized, which was hopefully going to give us all the answers that we needed. An excellent study in its setup, but sadly still didn't give us the answers that we wanted. What did they show? Well, they did show that if you were on the once-daily preparation this time of tadalafil versus the on-demand preparation, which we often do give of 10 or 20 milligrams throughout the week, that you got better quality assisted erections with PDE5 inhibitors. And that rate was better. So almost double the number of patients had back to baseline erections on the medication if they were taking it once daily versus if they were taking it on demand. If you compare that to placebo, it was 3 times the number of patients compared to placebo who had back to baseline erections. That's while they're on the drugs at the 9-month period. But when then you stop the drug, gave it a washout, and then reintroduced PDE5 inhibitors back in again, everyone responded the same. So it didn't almost matter if you had no PDE5 inhibitors for the 9 months before then. So again, it answered some questions and then left some new questions in its place. One thing this study did show, however, was that the amount of change in the penile length was less in the guys who had it as a daily basis. And this is interesting because this is part of that pathogenic mechanism we spoke about, the amelioration of those changes, the ultrastructural changes to the penis. Could this be what's going to be the holy grail in the future? The answer is we don't know. The study wasn't powered, it wasn't long enough, and maybe if it was for a bit longer, we may have got more of an answer. But as things stand at the moment, that's the best level of evidence we've got. Now, since then, there have been meta-analysis looking at all the different studies, and they've concluded that actually there doesn't seem to be any benefit of giving daily versus on-demand medication, but that is mostly centered around the larger studies which have been not using tadalafil. If you looked at some of the post-hoc analysis, in fact, in that REACT study, they found that if you took out subsets of patients who had really good erections beforehand, they were younger, they were more motivated, they actually had the best outcomes from having daily PD5 inhibitors. The literature does suggest, however, from the meta-analysis, that giving something is better than nothing. Starting it earlier is much better than starting it late, and in fact, starting immediately after surgery is probably the best time to do so. As far as cost-benefit analysis has been, this has always been one of the bugbears within the NHS. If we're not doing much difference, why are we spending so much money of the NHS trying to make things better? The landscape is changing. Cialis has just come off patent. The cost of the drug has gone down from £60 a month to now about £4 a month. It may change the way in which we can prescribe things. It may change the way in which we can do longer-term studies. And maybe we'll get better answers as time goes by. So coming back to the original question, what is the optimal program for patients who have got radical prostatectomy to give them the best outcomes with erectile function? Just as Declan said, it has to start before the operation. Those patient seminars are absolutely essential. And just as Declan said, you have to have that regret protocol within it as well. When we do ours at guys, we'll show these guys what a penile implant looks like, what a sphincter looks like, what does a Cavaject injection look like, what does a pad look like. Some guys have never even seen what they may have to wear afterwards. And you show them this beforehand, it gives them a proper understanding of what life may be like afterwards. Give them an idea of all the different things that could happen to them, not just erectile dysfunction and incontinence, but all the other changes to their life as well, so they understand and that you're all singing from the same song sheet. But when it comes to the actual protocols, people do divide it into non-nerve spare and nerve spare, but actually what you do is pretty much the same across the board. The only difference being is that if you've had a nerve spare approach, PD5 inhibitors have more of a role to play than if you've not had a nerve spare. What I do in practice, based on the available evidence, which I have to say is not brilliant and hasn't got that much better over a decade, is start patients on a vacuum device as early as possible. Around about 4 weeks is when I start. I think if you start it too soon, patients don't like it because they'll draw out some of the urine from their early incontinence. It'll put them off the pump for life. So around about 4 weeks to 6 weeks seems to be the most ideal time as the continence is starting to return. If they have had a nerve spare approach, put them onto a PD5 inhibitor. The evidence would say it doesn't make too much of a difference between giving on-demand versus daily. My personal feeling is I think probably once daily is better if you're using tadalafil only, and maybe the prescription or prescribing practices in the NHS will change as the cost has changed as well. But if they're not responding by 3 months, and many patients don't respond by 3 months, you're not expecting a full-on erection good enough to have sex at 3 months, but if they're showing no response, I'd switch them to an intracavernosal injection. And again, because we would have spoken about this before the operation, they are prepared to do this from 3 months onwards. Carry on with that for a period of time, and then you can think about reintroducing PD5 inhibitors later down the line, depending on their responses. Don't forget about psychosexual counseling. The impact of changes to sexual function to relationships can have a huge impact on their overall kind of couples' relationships, and that can also impact on their sexual function as well, so that should always be part of it. It's interesting, if you look at what Francesco Montorsi does, he's done several of these studies. He does something very similar. Sometimes uses the vacuum device, but he puts all patients onto on-demand PD5 inhibitors and starts them all onto Cavaject from about 3 months. But he'll interpose Cavaject 2 to 3 times a week, and on the days he's not giving a Cavaject, he'll tend to give them some form of on-demand PD5 inhibitor on those days as a way of trying to hedge his bets. And sadly, that's what we're all doing. We're kind of hedging bets more than anything based on the available evidence. So coming back to the original question, what is the optimal program again? It doesn't exist. It's all about using what is the best possible regime from the best possible available evidence at the moment. And despite 20 years of there being programs for this, we still don't have the perfect answer. What we do know is that doing something is better than doing nothing. That's absolutely clear. Starting early is better than starting late. And in fact, if you start in the first month, it even seems to be better than starting at 3 months. So really getting patients involved from the outset is the most important thing to do. Rehabilitation with intracavernosal injections seems to give you the best outcomes from data. They are smaller studies, but they seem to be the best results so far. So think about it as part of your program. PD5 inhibitors, that brilliance inside the kind of clinical studies and the in vivo models is fantastic, but it hasn't really translated into actual patients' use. Maybe as time goes by, and like I said, with further uses and more studies using PD5 inhibitors like Cialis on a daily basis and for a longer period of time, we'll get a clearer answer. But as things stand at the moment, it's difficult to recommend daily dosing otherwise. And we still need to do a lot more work to find out what the optimal regime is. But until then, that's not a bad one to use. Thank you.
Thank you very much, Madge. Any questions? Gentlemen.
Yeah, Matt, thanks very much. Penile, Cancer Group. I was talking to John Moorhouse last night, who says he now preconditions.
Yeah.
So 2 weeks of sildenafil pre-op. Comments on that? Is that evidence-based?
Yeah, so from the animal model point of view, it seems to make sense. There is some evidence to say that giving PD5 inhibitors has a neuroprotective role. And so when they've looked at the kind of cavernosal nerve crush models, if you give medication before you crush the nerves, it seems to have differential responses down the line. But that's based on in vivo work, not actually in patients. There is some logic to it, and I have to say, personally, from my point of view, if I'm seeing someone, I would put them onto Cialis 5 milligrams once a day pre-surgery. That's what I do. But the evidence is not strong for its clinical use.
Yeah, sure.
Gentleman behind.
Mike Fraser here from Glasgow. I'm just as confused as you are. But I think we should all throw away the PD5 inhibitors for 6 months. This preconditioning thing is nonsense, and we know it's nonsense. It's similarly nonsense to give people daily PD5 inhibitors for 6 months when it does nothing. That's firstly a waste of the country's money, and it dispirits a guy who gets no response. I think the only paper we should go back to is Francesco Montosi's 3 times weekly injection. Now, we know that guys don't like injections, but you've got yourself, what you've got to do really, I think, with my experience, is set them all up, set them at a target. Because all these guys that hang around at 3 years and go, well, yeah, it might get better, I'm hoping for it. Give them a point, at which point they're either doing well with injections, unhappy, or they get an implant. Because the IIEF score is the enemy of the penile rehabilitative doctor. A 4-point improvement in your IIEF score is not an erection you can hang a wet towel on, I'm afraid.
Mike, I totally agree with you as well, and that's why I think it's got to be about getting back to baseline, having an erection which is good enough for intercourse. That's the real goal here. It's not about anything else. And I do totally agree with you, and that's why, from my personal point of view as well, I use the intracavernosal injections. And the drop-off or the uptake is not as bad as people say. If you condition the patient beforehand to say, this is what we're going to do, and we're going to do this from this time, and it's going to scare you, but I'll show you how to do the injections, and it's not as bad as once you've done it. I have to say from my personal experience that the uptake has not been that bad. Patients do stick to it because they know that they've got a program in mind. And I think you're very right. One of the worst things is you get lots of these guys waiting endlessly for the 2-year, the 3-year, I'm still going to recover, I'm still going to recover. I think you do have to draw a line under when you're going to stop, and when do you move onwards. How do we define that period of time? That's not so clear. That's a little bit harder to say. Some people have argued for 18 months after a nerve spare. Other people have seen recovery past 18 months. I've seen a recovery past 18 months. So when do you draw it? It's like with all things, when you draw a nomogram and you're trying to define what's the normal limit, you've got to draw the line somewhere, and you'll capture most patients when you draw that line. There'll be some who would have missed. Personally, I think 18 months is probably sufficient after radical prostatectomy for a nerve spare. If they haven't recovered, they're probably not going to. That's what my feeling is.
Roger.
Hi, Roger Kirby. Yeah, I'm unusual in that I've done 2,000 robotic prostatectomies. Then I had one done on me by Ben Chalicum and Procar, and I can tell you firsthand, Cialis 5 milligrams a day works really well. So I would definitely advocate that.
There you go. The evidence is there. Thanks, Prof.
Final question is Declan. You've got your hand up.
Do you think there's an issue in mixing PD5 inhibitors and the injection? Because the way they work, if the tablets aren't working, are they going to increase your chance of priapism?
Yes, they do. So I wouldn't give them at the same time. So what Francesco Montosi does, where he gives kind of intermittent days of other things, you don't want to be doing that with something like tadalafil, because that'll have a hangover effect and increase the chance of priapism. So I've seen 2 patients who've had that.
And do you think patients and GPs, it'd be less hassle to go for the 3 times a week injection rather than the pump? Do you think, do they hate both equally and therefore just go for one that appears to be better?
To be honest with you, I think patients just want results, and even with the best of intentions, if someone starts using the vacuum device, most of them will stop doing it after a few months because they haven't got their erections back. They're sitting there having to fiddle with this machine twice a day, and even the most dedicated guy starts to give up after a period of time. I think the best thing that should happen is that patients should be coming in to have their radical prostatectomy. They've had their pre-operative screening done, and this is what we're starting to do at Guy's now. You will give them their vacuum pump before they go home. You should give them their tablets, if they're going to have tablets, before they go home. They should have their injections or their appointment to come back for their injections at 3 months. And if you do that as a set routine from beforehand, they know what they're buying into. They know what they're going to have. They don't have to struggle about what they're going to get from what GP and what the regulation is going to be for the local prescribing. If you're a centre that's doing radical prostatectomy, you're creating the carnage, let's deal with the carnage at the same centre. It makes sense. And if that all fails, then that's the same centre that can come back and you can have your implant put back in again. And as you said, at the end of the day, telling that patient that we're one way, in some shape or form, we are going to get you having sex again. It's just a matter of what threshold and what tool we have to use. And we're going to start with the simplest and we'll go to the ultimate, but we'll get you having sex if that's what you want. And they know they can do that in the same centre that they've had their radical prostatectomy done. It's perfect. That's proper holistic care.
Thank you very much, Madge.
Thank you.